So thank you so much for inviting me to be part of the symposium today, and thank you to all our colleagues for joining us this morning. So I will be speaking about breast cancer risks, genetics, and risk stratification. So let's first look at the risk factors that increase our risk for developing breast cancer. So increased breast density increases our risk. There are certain reproductive factors such as late menopause, late age at first pregnancy, low parity. Increased estrogen can increase our risk to develop breast cancer, and that includes both exogenous and endogenous sources of estrogen. There are certain lifestyle factors, and these can include increased alcohol intake, smoking, and a diet that consists of high fat. Radiation, especially in the chest area, can increase our risk to develop breast cancer. Age is certainly a risk factor and maybe one of the most important risk factors. And we know that our risk of developing breast cancer increases, especially over the age of 50 years. Family history is also an important risk factor. So if somebody has a first-degree relative with breast cancer, their chances of developing breast cancer are nearly twice as much as somebody in the general population who doesn't have a family history of breast cancer. And then, of course, there are the genetic risk factors, which are really going to form the basis of my talk this morning. So if we're going to talk about genetics and breast cancer, it is really important that we distinguish between somatic mutations and germline mutations. So if we talk about a somatic genetic mutation, these are mutations that are acquired over one's lifetime, okay? These mutations are going to only be found in the tumor cell. So if you had to biopsy a breast tumor, you're going to find mutations in there, and you're not going to find those mutations anywhere else in the body. They're completely isolated just to the tumor. These types of mutations cannot be passed on to children, but these types of mutations can lead to cancer. Then we get germline mutations. Now, these are the types of mutations that are inherited, and they are found in every single cell of the body, including the tumor. So these are the mutations that can be passed on to children. And if one is born with such a mutation, it can significantly increase your cancer susceptibility risk. So really what I'm going to be focusing on is when we talk about genetic cancers, we are really talking about those germline mutations. So let's just get a little bit of an understanding of how these mutations work to increase the risk of developing cancer. So we get different types of genes in the body, which when they are not working the way they should be or carry a type of mutation, they can cause abnormal cell proliferation, which can then eventually lead to cancer. So one of these types of genes, as an example, is called a proto-oncogene. Okay, and so what we will remember from biology is for every single gene that we have in our body, we always have two copies. A maternal copy and a paternal copy. Now, with proto-oncogenes, you only need one copy of that gene to have a mutation for proliferation to be activated. In comparison, we have something called tumor suppressor genes. Now, the majority of the genes that are involved in hereditary breast cancer syndromes are tumor suppressor genes. Now, how these ones work is for cell proliferation to happen, you actually need both copies of that gene to carry a mutation. So different to our proto-oncogenes. So let's just have a look at how that transpires when we have a hereditary cancer syndrome. So if we look at a hereditary cancer syndrome, what that means is you are already born with one copy of your gene having that mutation. Okay, but before that cell proliferation happens, we need the second copy of that gene to also acquire a mutation. So the second hit is an acquired or a somatic mutation, but now overall, you've got both copies of your gene that are not working and are mutated. So the first hit happened as a germline mutation that you were born with, and the second hit happened over time as an acquired mutation. So that is what happens with the hereditary cancer syndrome. If we look at cancer that happens that's not hereditary, essentially what happens is when you are born, both of your tumor suppressor genes are functional and do not have mutations. But over one's lifetime, you would require 2 hits, okay? So you acquire one mutation on your one copy, and then over time you acquire the second copy. Okay, so that is why when somebody has a hereditary cancer syndrome and has inherited a germline mutation in one of these cancer genes, we say they are essentially born with an increased susceptibility of developing breast cancer because they only need to acquire one more hit for that cell proliferation to happen. Okay. So let's look at some of these gene culprits involved specifically in hereditary breast cancer. So if we look at breast cancer cases in general, approximately 90% of those cases would be sporadic, which means they just happen by chance. Okay? And approximately 10% of all breast cancer cases are hereditary breast cancers. Okay? And that's where we inherit that one faulty copy already and are predisposed to developing cancer. If we break up those 10% cases that are hereditary, and we look, these are the gene culprits. So these are the types of genes that tend to be mutated that increase our risk to developing breast cancer. What is very clear from the graph is you can see that by far the majority is caused by mutations in the BRCA1 and BRCA2 genes, which I'm sure many of you are familiar with or have heard of. And the reason for that is because they are the most common hereditary cancer, breast cancer genes. It's BRCA1 and BRCA2. But it's not just BRCA1 and BRCA2. So even though those are the ones we talk about more commonly, as you can see, there are a host of other genes that are also associated with hereditary breast cancer. So in this table, I just wanted to summarize some of our main high-risk culprits. So I know with a lot of these talks, the emphasis tends to be on BRCA1 and BRCA2 mutations because they are the more common ones. But really for today's talk, I wanted to move away from that. And I wanted to show you and really emphasize how there are these other genes that we need to look out for and that we need to understand and know about because they can also lead to a very high chance of developing breast cancer. So I won't go into detail with all of these, but the main point that I wanted to show is if you look, these are some of our high-risk hereditary breast cancer syndromes, okay? So some of you may have heard of Li-Fraumeni syndrome, hereditary diffuse gastric cancer, P10 hematoma, etc. These are the genes that when these genes are mutated, cause these specific cancer syndromes. And if we look in the third column, we can see what kind of breast cancer risks are associated. So when you have a mutation in one of these genes, these are the kinds of lifetime risks we are seeing for a patient to develop breast cancer. And what you can see from some of these is that some of these genes are actually higher than the BRCA risks. So for example, if somebody has got a mutation in their TP53 gene, the risk can be higher than 79% of developing breast cancer. If somebody has a mutation in their P10 gene, the lifetime risk of developing breast cancer is 85%. Now that is significantly increased compared to general population risk. We also have some other genes that we call the moderate susceptibility genes that incur about a 15 to 40% lifetime risk of developing breast cancer. Now, what's also important to mention about these hereditary cancer syndromes is that they don't just predispose to breast cancer, but they predispose to a host of other cancers as well that would be really important to be aware of. So what we as genetic counselors would do in a clinic is when we're taking a family history, we would want to ask specific questions to see if any of these cancers have also presented in the family, because that might give us a clue as to what hereditary cancer syndrome we might be dealing with based on the presence of other types of cancers in the family. Now, while on paper it might look quite simple, where things can get complicated is there's definitely some overlap, okay, amongst these cancers. So sometimes you might look at a family history and you might have a very clear picture about what hereditary cancer syndrome you might be dealing with, but other times it might be less obvious because of the overlap in shared cancers in these syndromes. And that's where genetic testing really becomes important in guiding us to find the correct diagnosis. And we'll talk about that a little bit later in the presentation. So with all of these genes that I've just spoken about, all of them are inherited in an autosomal dominant fashion. So what that means is of our 2 copies, so you are born with the 1 copy of that gene mutated. When you then have children, there's a 50% risk of passing down that mutated copy to your child, or 50% chance of passing down the non-mutated copy to the child. So for each pregnancy, there's always a 50% chance of passing down the mutation. If that child then inherits the mutation, they would also have the hereditary cancer syndrome and be at increased risk of developing the cancers that have been associated with that syndrome. So what do we do in terms of risk assessments to try and have a better understanding of who qualifies for genetic testing and who might be at higher risk of developing a hereditary cancer syndrome? So the first way is a manual risk assessment, just by assessing the family history. So the first thing that we would look at is young age of onset. If you recall, we said that the biggest risk factor for breast cancer is an older age, is as you get older. So as soon as you see a young patient, you start to worry that this might be a patient with a hereditary cancer syndrome. We use an age cutoff of younger than 40 years for Caucasian patients and an age onset of younger than 50 years for African patients as being considered high risk. If a patient has more than 1 primary tumor, for example, a primary breast tumor and a primary ovarian tumor, that would increase their risk of having a hereditary cancer syndrome. Somebody with bilateral disease, somebody who has a family history of the same or related cancers, a patient with triple negative tumor histology. So specifically with BRCA1 and BRCA2 mutations, we know that triple negative tumor histology increases the risk of having a BRCA mutation. If we see the presence of a rare cancer in a family, so for example, male breast cancer, that would increase the risk that there's a hereditary cancer syndrome. And for some of these cancer syndromes, there's high risk ancestry associated. So we know there's a higher prevalence of BRCA1 and BRCA2 mutations, for example, in our Afrikaner and Ashkenazi Jewish populations. So all of these factors would increase the risk that there's a hereditary breast cancer syndrome. Then we've got more sort of objective criteria that we can use to do our risk assessments. So this is called the Manchester scoring criteria. And essentially what it does, so this is specifically only for BRCA1 and BRCA2 mutations. It looks at the family history of different cancers and the age of onset of those cancers and assigns it a specific score. Obviously, somebody who developed their cancer at a younger age would score higher than somebody who developed their cancer at an older age. It also looks at the types of cancers in the family, and it looks at the tumor histology. And so what you do is, and you add up all these scores, and a combined score of 15 to 19 points is equivalent to a 10% risk of having a BRCA1 or BRCA2 mutation, and a combined score of 20 points is equivalent to having a 20% risk of having a BRCA1 or BRCA2 mutation. And so how the scoring criteria works is we would say anyone who has a score of 15 points or more would qualify for BRCA1 or BRCA2 testing. What is important to mention, though, is that this scoring tool was validated in a UK population, and so it may not be very accurate in other populations, for example, our African population. Another tool that we use is called CanRisk. This used to be called Boadicea, if anyone has ever heard of that. And this is an online tool that you can access for free online. And essentially, you populate information on family history, whether there are mutations in the family, you input lifestyle, hormonal, and clinical features into this tool, imaging risk factors. And what it does is it predicts the risk of that patient developing breast and ovarian cancer. And it also predicts the probability of them carrying a pathogenic variant or a mutation in those high-risk cancer genes that we spoke about. So this is also a very useful tool to try and evaluate whether your patient is at a lower or higher risk of having a hereditary cancer syndrome, and can be very helpful in the clinic once we are doing risk assessments. Okay, so if we look at genetic testing for these cancer syndromes, we previously used to only test for BRCA1 and BRCA2 because they were the most common. But now we are moving away from that, and we are now moving towards multi-gene panel testing, and that's really what's recommended globally. So these are gene panels that include multiple genes that have been associated with hereditary breast cancer, and you test all these genes at the same time in a single test. So this is a more cost-effective way of testing. So doing a panel of genes actually costs exactly the same as doing just BRCA1 and BRCA2, sometimes even cheaper. And if there is a hereditary breast cancer syndrome, you are going to get an increased diagnostic yield because you're now increasing the chance of actually finding the mutation if it is a hereditary cancer syndrome. Now, depending on which laboratory you use, there are different options available in terms of how big or how small these panels are. So I've just put an example here of what would be considered a guidelines-based panel. So these are really the high-risk genes that we know are associated with the high risk of developing breast cancer. And we have well-established clinical guidelines associated to each of these genes. So if we find a mutation in one of these genes, we have clinical guidelines to know exactly how that patient should be managed going forward. So a clinician could choose to just stick to doing the guidelines panel. Then we have the options of doing extended panels, where a clinician might choose to add genes that perhaps have preliminary evidence of being associated with breast cancer. And then we have things like multi-cancer panels, which can consist of close to 100 genes on the panel, which include genes that have been associated with a variety of cancer syndromes. So might not be contained just to breast cancer syndromes, but multiple other cancers as well. And so just to say that we have local laboratories that offer these panel tests, as well as international laboratories, and we use a mix of both when we test our patients. And also to say that in the last year or so, our state testing through the NHLS in Bloemfontein has also now introduced multi-panel testing, which is really great for our patients. So we can also offer our state patients better testing and not just BRCA1 and BRCA2. So what are the clinical consequences? Why would we want to know if somebody has a hereditary breast cancer syndrome? So the first thing is because it has implications for that patient's management and treatment. Once somebody has been diagnosed with a hereditary breast cancer syndrome, they would be eligible for increased screening, okay, which could include mammograms and or MRI, which would start at a younger age compared to population screening and would occur more often. That patient could also be offered prophylactic risk-reducing surgery. So for example, a bilateral mastectomy, which could reduce the risk of developing breast cancer by 90%. And something like a prophylactic oophorectomy, if ovarian cancer is one of the cancers that's associated with that syndrome. Okay. There are also targeted therapeutics that might be available. So depending on the specific mutation that we have found, there might be a targeted therapy that can greatly improve outcomes for that patient. So one of the most common ones are PARP inhibitors, which are used for BRCA positive patients. There are also then more reproductive options available for patients. So if you have a young patient who now knows they are going to be in chemotherapy and they are worried about preserving fertility, we can offer things like egg retrieval and freezing if we know we need to start that patient on chemotherapy early. Also for somebody who might be considering things like prophylactic surgery, even if we would only most often for something like a prophylactic oophorectomy, you would only consider that between the ages of 35 and 40, but depending on the family history, if you wanted to do that surgery earlier, these are the things you can consider. So at least you can give your patient some options. And then, of course, we have the issue of at-risk relatives. So once you've diagnosed a patient with hereditary cancer syndrome, you now have a whole family who is at risk of carrying the same mutation and being at the same cancer risks. So genetic counseling and predictive genetic testing can then be offered to these at-risk relatives so that they can clarify their risks and can also have the management and treatment options available to them prior to developing cancer if they are at risk. So I just wanted to speak a little bit about genetic counseling, which is the profession that I'm in. So the role of the genetic counselor is, well, we are allied healthcare professionals who are trained at the master's degree level, and we are there to provide accurate risk assessment. So we will analyze the family history and do a risk assessment to see if patients are at low or high risk of having a cancer syndrome. We offer education and support to patients and their families. We can select genetic tests appropriately and offer patients the correct interpretation and explanation of genetic test results. We can explain complex concepts to patients about genetics. We help facilitate informed decision-making regarding testing and management decisions. And then we also provide psychosocial support to all our patients as well. And so I just wanted to take this was from a study that looked at patients who underwent genetic testing, who had genetic counseling versus who didn't. And it showed that the patients who had genetic testing, who received pre-test or post-test genetic counseling, show greater knowledge, a better understanding of the results, improved decision-making, decreased distress, greater satisfaction with the testing process compared to patients who did not receive genetic counseling. And so where can you find us and where can you send your patients? So our unit has genetic counseling clinics at the Helen Joseph Hospital, Charlotte Maxeke Hospital, Barra. We run an outreach clinic at Potch Hospital as well. And then we run our private clinic at the Donald Gordon. For patients who might be further away from us, but have access to online tools, we can offer online consultations as well if access is a problem. So we will always make a plan for your patients. I've left our contact details over there so that you know how to find us. Okay, and then just some take-home messages. So genetic counselors are part of your healthcare team. It's important to refer patients with early onset cancer and or a family history of cancer for genetic counseling and testing. Look out for a family history of breast, ovarian, prostate, pancreatic, and melanoma cancer. And a diagnosis of a hereditary cancer syndrome has clinical implications for both the patient and their family, and it is important that we remember this. Thank you.